Hi, my name is Jo Gibson and I'm a clinical physiotherapy specialist working at the Liverpool Upper Limb Unit in Liverpool in the UK, and I'm also a consultant in private practice. It's great to be here again for our second offering in terms of our Facebook Lives. Last week we kicked off with special tests. Now, I'm sure you're aware that this is all part of my involvement with the lovely David Pope at Clinical Edge, and you can still access our free webinar series at clinicaledge.co/stiff shoulder. Now, what am I going to talk about tonight? Well, really, I had all sorts of ideas, and certainly there's still some things I need to answer from some of you that joined us last week. However, on Thursday last week, I was covering clinic for a colleague who was having some well-earned holiday, and then I had a session in the private practice on Friday, and it really was neck and shoulder week. I don't know what was going on. In the clinic on the Thursday afternoon, we had 3 patients with apparently very stiff, very painful shoulders who were atypical age group. So we had a 63-year-old with an insidious onset of shoulder pain, really struggling, horrible sharp shooting pain and profound stiffness. We had a 32-year-old, again, stiffness, really struggling with the level of pain that she had, no particular mechanism of onset, and another patient that was very similar to the first one I described. On Friday, I had 3 guys, one who'd had an original history in the gym, somebody again with no apparent onset, but literally the consistent theme with all of them is that I strongly suspected the cervical spine was involved. And so I thought actually that would be a great thing to discuss this evening in terms of when do we suspect the cervical spine? Does it matter? Why does it matter? And what influence might it have on our treatment? But also importantly, those things in somebody's history, how they describe their pain, what makes it worse, what makes it better, how actually can we use the best of the evidence that's out there to inform our practice, whilst being honest that sometimes it's not always possible to differentiate these things, and actually adding the cervical spine into our shoulder treatment probably has a really good evidence base anyway. So guys, I'm going to get started. So what was I thinking with these 3 patients? Well, the one that really triggered it off was a 63-year-old lady who had really significant restriction in terms of external rotation. So my colleague came and presented them, did a lovely presentation and said, but she doesn't fit a frozen shoulder. Her onset in that she didn't have that horrible painful phase, it's just been painful and stiff. There was no kind of build up. There was definitely no trauma. So again, that could fit into a frozen shoulder. But the most obvious thing is she's 63, which is outside the typical age range. Didn't have any history of diabetes, but also was clearly very distressed by the pain. Now, interestingly, she was all right at night. She says she doesn't ever lie on her side anyway. She usually lies on her front, but currently she can't lie on her front because it gives her shooting pains down her arm, but she can lie on her back if her neck's nice and supported. So the key thing with this lady really is it illustrates quite a few things that are out there and challenging our thoughts about stiff shoulders at the moment. The lovely Karen Ginn has done some super work showing that patients who'd been given a diagnosis of frozen shoulder were taken to theatre, put under anaesthetic, and had a significant increase in range, suggesting that actually they weren't a true frozen shoulder, they had a muscle guarding issue. Now, this lady had a real marked restriction to her external rotation, but again, because of the history I was getting and where her pain was, and I'll come back to that in a moment, I was very suspicious, as was my colleague, that this was likely to have a big contributor from her neck. But my colleague said, but her neck movement seems okay. When she moves, it's not reproducing any shoulder pain. So again, what helps us being more confident that the cervical spine might be an issue? Now, I went in to see this lady and she was clearly very apprehensive, clearly wasn't sleeping, struggling in terms of the level of pain, and was obviously very reluctant to move because if she did, she got this sharp shooting pain down her arm. Now, one of the things I find quite useful in terms of working out, particularly when I'm suspicious it's not true stiffness, is just unloading the arm, but also putting my hand kind of in the axilla as I'm externally rotating so I can actually feel if the patient's fixing with their lat dorsi or not. And this lady really was. So I then did a few other things, which I'm going to share with you just in a moment. But let's go back to her history and her pain descriptors and think about the things that allow us to strongly suspect that the cervical spine's involved. There's no doubt if you look at studies that have tried to extrapolate meaningful information about pain location and aggravating and easing factors, there's been a couple of really nice systematic reviews of all the evidence that's out there. There's no doubt that if somebody has scapular pain and posterior shoulder pain, then there's no doubt differential diagnosis of the cervical spine should figure. Similarly, if we look at an older population who have any kind of global hand symptoms, so not dermatomal, but again, that generalized feeling of pain in their hand, and particularly if there's some associated pins and needles or numbness, that's highly correlated with facet joint OA in an older population. Now, it's easy if somebody comes with a cervical radiculopathy that's very dermatomal, they've got a very clear pattern of distribution. But in this, we're really talking about those patients that potentially have an overlap of cervical and shoulder pain. So, as I say, if we look at these studies, posterior shoulder pain, scapular pain, there were some nice studies that looked at stimulation of the anterior disc and the facet joints with hypertonic saline and described these cloud zones, which are very definite areas of referral in the medial border of scapula. Similarly, any pain into the upper traps. Now, again, we have to be careful. If we think about the AC joint often doesn't refer much past the shoulder, but can refer up into the lateral cervical spine. But as well as those kind of descriptors of pain, the important thing is what makes the pain worse and what makes the pain better. Now, interestingly, again, this lady said that if she supported her arm in more of an abduction position, then actually if she could get it comfortable, it gave her some relief. And a typical thing that patients with a cervical driven shoulder pain will tell you is they like the arm either to be in a sling position or above their head or in this supported abduction position. Now, any of you who've seen anybody with a true shoulder-driven issue knows that they don't want to be up here and they don't want to be up here. They might want to be here. So again, we need to be honest that some things are very useful, some things not so much so. But what about this concept of neck movement and whether or not that's sufficient to rule in or rule out somebody's problem? I commonly have people come and say to me, oh, well, their neck movement's fine and neck movement isn't reproducing their shoulder pain. Is that enough to rule out their neck? Well, no, particularly if you have local symptoms around the scapula and the posterior shoulder, and particularly with radiation below the elbow. Bit of a no-brainer, particularly if we have associated pins and needles and numbness. But none of the patients that we saw in the clinic or on Friday had any associated neurological findings. 3 out of the 6 had some referral either into their hand, in their forearm, but the other 3 just had scapular pain, some neck pain, and very definite shoulder pain. So in terms of ruling out the cervical spine, what gives us best value? Well, there's no doubt that if somebody looks like they've got okay range of movement, firstly, we need to overpress it. Secondly, if that doesn't give them local pain, it doesn't have to reproduce their shoulder pain, but if it reproduces local pain on the same side, that can have some relevance. Similarly, if we do our Spurlings or combined extension rotation, if that's negative, with overpressure of range of movement being negative and just general palpation down the anterior pillar, or if you want to lie your patient down and palpate, if those 3 things are normal or don't reproduce any symptomology, then you can confidently rule out the cervical spine. Now, we need to be really careful. If you look at patients with shoulder pain, particularly if they've had it for any length of time, again, the evidence is really clear that around 40% will have some cervical spine involvement just because of the way they've been moving and the way they're likely to have compensated. So again, we have to be a little bit careful. Now, in terms of things that make it worse, then again, no great surprise if you've got somebody with a very specific shoulder pathology. Generally, there's a definite mechanical pattern to the things that cause them a problem. Whereas with our cervical spine, they often find sustained postures and being in one position much more provocative. But remember that lady I told you about? She was very clear that just taking the arm away was really sharp, horrible pain, but it was shooting her down the arm and the posterior aspect at the same time. As I say, no mechanism of injury, and she was atypical to have that stiff shoulder. So why are we interested in ruling in the cervical spine or ruling it out? Well, the first thing is that essentially if somebody has neck pain associated with a shoulder problem, we know that on average they can take twice as long to respond to our interventions, probably because of the impact it has on pain sensitivity, but also you've got 2 or more areas of musculoskeletal pain. Importantly, if you've got somebody going for surgery or somebody who's had trauma who has a pre-existing neck issue, so trauma or surgery to their shoulder, again the evidence is clear that they'll have higher levels of pain, and again their recovery is likely to be a little bit longer. So it is definitely worth consideration. But how, again, what things can we do objectively? We've said what we can do to rule it out, but what can we do to establish whether it's going to give us good value in our treatment? And again, what can I do in my assessment? Well, again, this is where repeated movements can be very, very useful. Now, in terms of repeated movements, there was a really interesting study by Paul Mintkin and some work by David Vanderput, which essentially took a load of patients where they did actually use special tests of the shoulder, like Hawkins and Neer, full cans, resisted tests, so pain provocation tests, and highlighted patients who had a history that was consistent with a cervical spine problem and those that didn't. Now, they further subdivided them in that essentially if those tests improved with postural correction, and they had some range of movement restriction and a cervical history, then that was one group. Then they had those that didn't have a cervical history, had some range of movement restriction, and or those tests improved with postural correction. And finally, they had a group that essentially had full range of movement, no change on postural correction, no history of cervical spine involvement, but they had those positive shoulder tests, suggesting they were a local shoulder problem. Now, what they did in all those 3 groups is they did repeated movements of the cervical spine and then reassess their tests. Now, non-surprisingly, up to 70% of the people that had a true history consistent with cervical spine involvement got a significant improvement in all those tests. However, a third of the patients with no history of cervical spine involvement whatsoever, no range of movement restriction, no improvement on postural correction, also got a significant improvement when they retested their tests. So what does that tell us? Well, guys, we have a really nice evidence base. I know at the moment there's a massive move against manual therapy and its usage, but actually lateral glides to the cervical spine are probably one of the most evidence-based manual therapy techniques we have, in that they have been shown quite clearly both to increase pain pressure threshold, reduce muscle stiffness, very relevant in this lady, but also increase cuff activation. Now, of course, it's only temporary, and arguably what this other study shows, we can achieve exactly the same with repeated movements of the cervical spine, which is clearly something that's much more possible for the patient to do. So some very simple things. Now, I always like to apply my symptom modifications so I can unload C5-6, I can get them to sustain a retraction whilst they do their painful movement. But as ever, our subjective is absolutely key. In terms of the aggravating and easing, does it suggest it's more neck driven or shoulder driven? And remember, as we said, up to a third of patients can have absolute components of both. And so guess what? We're just going to incorporate both in our management. Now, in terms of the first lady I was talking about, who essentially was very, literally 5 degrees of external rotation, objectively looked like a frozen shoulder, but subjectively too old, not a consistent history, and that sharp shooting pain and the fact it was much more kind of abduction and elevation than external rotation. We couldn't move her far enough with her external rotation to aggravate any pain. So what do we do? Well, I could get her to do some repeated movements, and that would have been entirely reasonable. But essentially what I did is just lay her down and just have a palpate of her cervical spine and do some APs. Now, I guess in some ways that's against my usual approach, which is to do something which, if you like, empowers the patient. So essentially getting her to do something or changing her movement would have been the other way of doing it. But I did some APs, and essentially immediately we had more external rotation range, which obviously surprised her. But I supported her and did what I said about feeling in that axilla, and then just got her to do some gentle hold, relax, and talk to her, lots of reassurance and getting the arm moving. And we actually started to see a significant improvement in her external rotation range. So what does that tell us? Well, one, we know that any cervical involvement can have an impact on upregulating muscle stiffness in your biceps and in your pecs and your lats and those anterior muscles. We have evidence to support that. We also know that in terms of pain sensitivity, again, if you have significant cervical spine involvement, you're going to have a lot of local tenderness, particularly around this upper arm. There was a test called the arm squeeze test, which was described by a guy called Gamina, who essentially looked at comparing palpation around kind of the deltoid insertion with local palpation over the AC joint and then the subacromial space. And essentially, if pain down here was more than 3 points on a visual analog scale greater than these, it was more indicative that the cervical spine was involved. Now, guys, I think we have to be slightly cautious because obviously that tenderness can be modulated by many things. But really, what are the key messages that I want us to take away and what was really useful with all of those patients? I think the key thing was, even though certainly the 3 in clinic presented with significant stiffness and horrible pain, one, their pain distribution definitely included the cervical spine and that medial border of scapula and posterior shoulder, but also they were at an atypical age group to have significant stiffness. They didn't have any features in their past medical history, so with the younger patient, no history of diabetes or thyroid issues or other things that might predispose somebody to get stiff. And as I said, in the older lady, really outside that typical age range. In terms of their descriptors, both had constant pain. Both clearly had a lot of descriptors that suggested they had very negative pain beliefs. They had a lot of life stress going on, and with COVID at the moment and the impact it's having on people's lives, probably not terribly surprising. But what's really interesting, the lovely Elizabeth de Betz and another paper by De Silva et al. Shows very clearly that our patients that have high levels of pain catastrophizing or pain-related worrying, as we're now being told to call it, essentially have profound losses of lateral rotation movement. So again, we see that in all these patients, they had a lot of stress going on in their lives. What the lady that was 63 was on her own and had no social support and was clearly struggling with that, and again was scared that there was something seriously wrong because it turned out she'd had some health problems in the past. The young lady had loads of stress going on with relatives that she couldn't visit, a parent that she was worried about. Now, I'm not saying those things had caused their issues. The 32-year-old was now working at home on a laptop on her desk in what sounded like a pretty cramped situation. The older lady just wasn't doing any activity or going out anywhere. So of course we have to see that bigger picture. But as ever, I think what really this tells us is just by listening to that history in terms of where's the pain, what makes it worse, what makes it better, some very simple objective tests, and then appreciating those bigger aspects that can potentially influence how people are moving and profoundly affect muscle stiffness and their pain experience, then we really evaluate the things that make the biggest difference to our treatment. But in terms of all these patients who some had definite neck-driven shoulder pain, some had obviously a combination of both. What difference does it make to our treatment? Well, the good news is when we look at actually trying to target the cervical spine, there's no doubt range of movement stuff is very important. And we said in terms of those repeated movements, retraction's one of my favorites. Do I have a good reason for that? Probably not. It's just a hangover from my junior days, but again, it's where I'd normally start. And then rotation would be my next go-to in terms of range of movement. Somebody on one of the courses actually showed me a lovely idea with a Pilates ball to just unload the neck and do some active rotation. That can be a really nice way of unloading the neck, doing movement and combining it with some shoulder stuff. But importantly for me, it's about what do we do to just influence the shoulder and the neck muscles together. And the great news is we keep it really simple. Essentially, if you look at the evidence, just adding craniocervical flexion into your shoulder exercises is as effective in terms of affecting deep neck flexor function as taking somebody through those progressive lying down exercises with the biofeedback. So really simple things seem to work. Personally, if I have somebody who's got clear neck involvement, I'll often progress that to just get them doing some resistance against TheraBand. So whether they're in 4-point kneel or whether they've got their arms against the wall with the TheraBand around the back of their head and then retracting and rotating, it just gives them some really nice resistance to work against. Now that's fine when you've got some good foundations, but early in the intervention, you'll find sometimes it's a little bit much to have the arms unsupported. And so what you can actually do, some lovely work by Anne Cools, something as simple as a wall slide with some resistance around the wrists, just adding a shrug in at the start and the end of the movement and actually working them above 90 degrees gives you better relative recruitment of those cervical muscles, and importantly takes away the things that are off just working a bit too hard because of pain inhibition and those compensatory strategies. So I guess the key messages are, in terms of pain location, anything around the scapula, anything in the hand, anything below the elbow, be suspicious. It doesn't rule the shoulder out, but when they start telling you that pain is worse in neutral, in prolonged postures, and they particularly when they tell you they relieve their pain by putting their arm here or out to the side or even here, again, be suspicious. Nighttime is really useful. Is it worse lying on the shoulder? Might rule in the shoulder more. If it's not, and actually nighttime's not a massive problem, or they like lying on their back, then again, you can see how it sways you one way or the other. In terms of your objective, you can keep it really simple. You can do symptom modification in terms of an unload or a lateral glide, or even better, get the patient to do something active in terms of retraction, a rotation away, or some repeated movements. Remember, if you want to say categorically and confidently you've ruled the cervical spine out, range of movement isn't enough. But also remember, you don't have to reproduce somebody's shoulder pain for the cervical spine to be involved. If you reproduce local pain or you have movement restriction, we have some studies showing that cervical stiffness actually increases the risk of developing shoulder pain by up to 3 times, particularly in people who work in more sedentary jobs. So just getting range of movement seems to have some really good basis in the literature. Now, with all those patients, what difference did it mean? Well, it just meant that they went away doing neck stuff as well as shoulder stuff, and actually wherever we can, we, if you like, combine those things together, because we don't want to give patients too many exercises because we know that they won't do them. But as I say, such simple things like just including that cervical flexion, that craniocervical flexion, movements combined with the shoulder, again, a really sound basis in the literature. So guys, as ever, I've rabbited on for 20 minutes and hopefully given you lots of clinical tips and tricks. I think what it shows us is that the cervical spine, even in somebody with no evidence of a cervical component, we can use it in up to 1/3 of patients to modulate their shoulder pain. And that makes sense in terms of our neural supply to the shoulder. But those really are just some key things to share with you based on those patients that I saw in clinic. And as I say, it seemed to be a bit of an epidemic. But I think what's important to say on the back of that, all these patients were quite distressed. They had a lot of stressors going on in their life. And as I say, those 2 authors that I referred to, Lisbeth de Betz and De Silva, show us very clearly that increase in psychosocial stressors, those increases in pain-related worrying or catastrophizing, do have an actual impact on muscle stiffness and range of movement, and particularly external rotation in neutral. So again, when the age doesn't fit, when they're describing really high levels of pain, remember, in the absence of an acute cause of shoulder pain that could explain that pain, just think I might need to just investigate this a little bit further. Now, guys, I'm just going to have a look. I think we've got some questions. Tina, I know a lot of people with shoulder injuries end up having upregulated upper traps activation. It's still okay to give them shrugs with wall slides. I know it's likely upper fibers of trapezius is weak if that's the case, but what would you say about that, Jo? Hi, Tina. Great to have you here. So what I would say, you're absolutely right. Upper fibers of trapezius is generally weak or not doing its job well enough, actually, rather than being overactive. If we look at patient groups where it's truly overactive, then either people with a really stiff shoulder, so a true frozen shoulder or a post-op, or somebody with a massive cuff tear because they can't use anything else, or somebody with a nerve injury, again, suprascapular nerve, so they haven't got their cuff, so again, upper traps has to work too hard. But in the absence of those, if you see somebody shrugging at the beginning of movement with no rotation restriction, no weakness or history of a massive cuff tear, and no nerve injury, then it can actually be a nice indication that your neck is the key driver of that problem, because that segmental facilitation just upregulates upper fibers of trapezius. However, as you quite rightly say, if I've got somebody who comes to me with a shoulder problem, and I might just see upper traps bunching at the end of movement, if I even think it's worth looking at that, this exercise that I told you about will still work, because the basic premise is we're making life easier for the shoulder by supporting it. We're using our TheraBand to just get our posterior cuff working a little bit harder, or reminding it to do its job. And then importantly, just exaggerating the scapular component. So we're just really exaggerating all the things that will unload that shoulder, but importantly, if you like, change what they're doing around their cervical spine. So yes, and it's a lovely question, because it almost highlights and reinforces that very simple things have applications in lots of different patients. So as I say, the only caveat is they haven't got a stiff shoulder, they haven't got a massive cuff tear, they haven't got a nerve injury. But as you quite rightly say, in the majority of our shoulder patients who might then have developed cervical involvement, and again, that's quite a high association with long-term shoulder pain, certainly with AC joint injuries, then that shrug exercise would be just as appropriate. And the key thing, again, just to highlight, is doing it above 90 degrees seems to give better value when the neck is definitely involved. Oh, Katie, how do I do my lateral glide? So do it in supine, and I just hold the arm, that's not an arm, that's a head. I hold the head or the neck so it's in mid-flexion. If you look at the studies that looked at this, they just did the head supported on pillows. So again, they were in a little bit of cervical flexion, and then I just use this part of my hand going straight over the cervical spine. So essentially, if you like, I'm here. So interestingly, when you look at the studies that have done it, they've looked at doing it towards the side of pain and away from the side of pain. Doesn't seem to make any difference. We're just having some sort of modulating effect. And tonight's probably, I could speak for another half an hour about placebo, contextual factors, manual therapy. But as I say, lateral glides does have a good evidence base, and most of the original work was actually done in tennis elbow, and they noted the impact it was having on the shoulder. So some interesting findings. But literally in supine, I cradle the head, and then that's my kind of hand grip. But don't worry about it too much. The studies that showed a positive effect essentially supported in mid-flexion and lateral glides on that pillar. I might just try and click a picture onto the Facebook page so that you can see it. But thanks for your question, Katie. Thank you. Lucinda, hi Jo, you talked about treating your first patient AP. What do you mean by that exactly? I'm an osteopath, and I was imagining you were working on the thorax with thrust work, but you were talking about mobilizing the scapula. I'm so sorry. No, I was actually talking about an anterior posterior on the cervical spine. Now, interestingly, there was a study that looked at post-op patients and looked at using APs to actually modulate shoulder pain, and showed it was effective compared to a group who didn't have it. But essentially just doing an AP on the cervical spine here. Now, again, there's such a hoo-ha about manual therapy at the moment. The fact is, if you do something in the mid-cervical spine, if other things aren't changing, I would always want, where I can, to get the patient doing it with movement or retraction or changing something about load on that system. But I would be dishonest if I didn't say I use those things sometimes. So in terms of, Marlene, so the AP, yeah, that probably is a hangover actually from, I probably was taught that on my MACP, but as I say, there is a study, can't remember, Hausman, I think is the author, 2018, who looked at it in post-op patients. The lateral glides were described by Bill Vincenzino in Tennis Elbow, but have also been described by a few other authors now. I'll try and put some links to some relevant articles so you've got pictures of the actual techniques and how importantly they were implied in studies that showed an effect, rather than what I might have adapted in my clinical practice. I'll share the science with you, so I'll definitely send you those links. So Claire, hi Claire, would you also look at mobilizing the thoracic spine as part of treatment with both cervical and shoulder issues? I find positive signs of stiffness and pain here. Also, first rib is something that could be overlooked. Thoughts? So again, lovely question, Claire. If you look at the evidence base, and there's two answers to this question. One is the concept of stiffness in the thorax, and the second is whether to treat it or not. There is absolutely no doubt that there is a study that looked at adding the cervical spine and the cervical spine and the thorax into normal shoulder treatment for one group and not in another. Though both groups did exactly the same, what was interesting is the patients who'd had the manual therapy, their perception of change was greater. So patients felt they'd done better, even though objectively there was no difference between the groups. There's also no doubt, if you look at frozen shoulder, particularly in stage 1, there's more evidence to support manual therapy for the cervical spine and the thorax than there is anything to the shoulder. Now, we also know if we do manual therapy to the thorax, whatever we do, mobilizations with movement, soft tissue work, whatever, we have an impact on muscle recruitment. What do we mean by that? We just change muscle stiffness. And as you're absolutely right, if you look at patients who've had shoulder pain for any length of time, there is no doubt a lot of our patients present with rotation stiffness or extension stiffness. Now, what we have to just be a little bit honest and reflect on is if you look at the trends in how we address the thoracic spine, generally all our targeting is at improving range of movement. So it's all about range of movement, if you like. So stretches, thread the needle, leaning over the back of chairs. Now, I'm not saying there's anything wrong with that, but why are they stiff? Okay, if somebody had a stiff shoulder or let's say a GERD, we released it, they had more range, we'd then make them recruit through that range. And so all I would say is that if we're going to give patients thoracic exercises, we need to make them about recruitment rather than just stretches, so that we actually change what's driving that stiffness in the first place. I hope that makes sense. So again, there's no doubt that if we do something to somebody's thoracic spine, we all see great improvements, people feel great, and also when we look at just how it changes somebody's perception of movement, it's a very effective area just from a neural point of view. There's a reason neurophysios talk about central key points. There's lots of reasons that, again, I could talk for hours, but essentially it's a good area to target. But as I say, whenever I can, so the common thing for me is I'll get a patient coming in saying, oh, I've seen 5 other physios, I've still got my shoulder pain. I need you to manip my thorax or mobilize my thorax because it always makes me feel better. So my first question to them is, well, how long does it make you feel better for? Well, a few days, and I do my stretches, but then it gets stiff again. Well, okay, so what's driving the stiffness? I don't say that to them, but in my head, because we know that we can have an effect. Exercise, manual, all these things have a temporary effect, but how do we get that carryover? So in that situation, what I'll quite often do is usually choose rotation just because it's easy for them to feel a difference. Put my hands on their rib cage, give it a little bit of squeeze and a little bit of a lift, and show them that actually they can move a lot further. And they usually kind of go, oh, how have you done that? And it's purely that we're just getting them to work better in that mid-thorax. Now, obviously, I'm obsessed with my TheraBand as one of my foundation exercises. So for me, it's then just building that rotation into my shoulder exercises, and some really nice simple ways of doing that. If somebody's really stiff, we get really good value by doing exercises that do both arms at the same time. If you do both arms, you have to rotate your thorax. That's why tennis players who play with a two-handed stroke have less shoulder injuries, because thoracic rotation is really protective to the shoulder. So absolutely, Claire, in terms of the thorax, I always measure it the first time in sitting. In terms of extension, generally I find that improves significantly just by getting them working their system better, if you like, or just changing their recruitment by just getting them working differently. I'm getting very conscious of using all these words, you know what I mean? I'm changing their movement strategy. I'm giving them a sensory input to just change how it feels to move and making them more confident to move, and generally that improves that thoracic extension. If it doesn't, I would just exaggerate the kinetic chain. In terms of rotation, as soon as I'm confident that they've got good cuff function, then I'm just going to add thoracic rotation into their shoulder prescription if it's not changing. But again, one thing that's just worth you trying next time you see a patient, I'm sure you've seen me do this short lever through range with a loop of TheraBand with a step or a step up. look at their rotation in sitting, just do a couple of sets of that exercise and then sit them down and assess it again. And I promise you, in lots of your patients, it will be better because you've just changed muscle stiffness. The secret is what you give them to maintain that. Now, if that exercise worked, you've kind of nailed it. If it doesn't, you might have to do more specific to build in that thoracic rotation. So again, it's just shifting that emphasis to empower the patient so they achieve those things. They don't need us to do it to then do the exercise. And I'm not saying don't do them, because again, the longer people have had symptoms, the harder it is sometimes for them to change those strategies, particularly if they're a little bit fearful. So our hands on the thorax are a really good way of, if you like, influencing that body schema and changing how they're moving. But again, it's always important that it should just inform an exercise. So Claire, great question. I could talk about the thorax for quite a long time. Any more questions? Let's just have a little look. Guys, no, fantastic. Well, I've gone over half an hour again. I'm absolutely rubbish at sticking to time. I'm just going to whiz up here and just make sure I haven't missed any questions. As you can hear from the beeps, I'm not doing very well at getting to the top, but I'm going to assume that those are all the questions for now. Guys, thank you so much for joining us. You're welcome, Claire. It was a great question. All of you have asked questions tonight. Were just great. Thank you so much. It's just lovely to have people join in and have some discussion. I hope that's been useful. As I say, what I'm going to do is just pop some links to those key papers where it actually shows you how those techniques were applied in those successful studies. So keep an eye on the Facebook page. The other great thing is these are now getting posted on YouTube as well. So if people miss them or want to revisit them, you've got two options. You can go onto Facebook or just look up the Clinical Edge page on YouTube and you can watch them again too. Ruth, more info. Oh, perfect. Well, why don't we do the thoracic spine next Monday? Because that came up last time too. So thanks, Ruth. We'll do the thoracic spine next week. So join us then if you want to hear more about the thorax. A couple of really interesting patients I had actually just in terms of differentiating not so nice pathology, but we can also talk about some great rehab tips and tricks, and again, where does the evidence help us? So guys, thanks so much for joining as ever, and I'll really look forward to seeing you next week. Bye for now.